So I'm going to talk a little bit about hypoglycemia. It's not 100% tox, but lots of tox in it. I have no disclosures to give. A little bit of an outline, going to talk a little bit about the mechanisms of hypoglycemia and focus a little bit on the pancreas. The liver is in there too. Some agents that would cause hypoglycemia and treatment, which is probably the most important thing. Pancreas and liver are kind of best friends, and they're the most important part of this. When we have high blood sugar, right, that sends a signal to the pancreas. Pancreas says, oh my God, there's so much sugar. I'm going to put out some insulin, and then that's going to lower sugar. It also makes us make glycogen stores at that same time. And then when we're hypoglycemic, the pancreas goes, oh my God, I'm low on sugar. I'm going to put on, glucagon. And I'm going to go to the liver and I'm going to say, oh, turn that glycogen into glucose. And so you can imagine that either part of this, if impaired, can cause people to have hypoglycemia. Whether it's the pancreas and too much insulin or too much exogenous insulin, or somebody who has liver failure or drugs that interfere with this. So just zooming in to the pancreas a little bit, this is a beta cell, a beta islet cell. And this is probably the most important part. You have glucose come in, you get what ends up going through the citric acid cycle, and you generate ATP. ATP shuts down this potassium, ATP-sensitive potassium channel, which then opens up a L-type calcium channel. This is something also to think about with how we differentiate, and maybe you can remember this a little bit. Differentiating beta blocker overdoses from calcium channel blocker overdoses. When you have really high doses, the specificity for calcium channels for the heart can go also to the pancreas. And so that's why one way to remember that you're going to have hyperglycemia for calcium channel blocker overdoses is that you're going to block this L-type calcium channel. And then that's going to prevent the exocytosis of insulin. In there's also the insulin exocytosis is CAMP dependent, which we'll come to a little bit later. But essentially opening up that calcium channel leads to the exocytosis of insulin. So what's like a good differential, and I have a lot of things written down here, of hypoglycemia? Like, what are you thinking of? Yeah, so I'm here, so we're probably talking about sulfonylureas, sepsis. In this case, maybe not as much we're going to focus on, but kind of, sorry?
The beta blockers.
Beta blockers really only in kids. Like I wouldn't think, for most adults, we don't see them being hypoglycemic from beta blocker overdoses. Calcium channel blockers, definitely. Kids who have like lower, glycogen stores, they're more likely to get it, although it's not so clear how often it happens. So don't think, if they're not hypoglycemic, you're not ruling out a beta blocker, but if they're not hyperglycemic, it's probably not a calcium channel blocker. Sorry? Adrenal insufficiency, liver failure. Alcohol, especially for kids, does happen in, our alcoholics as well, but especially for kids. That's kind of enough. There's a lot of weird, crazy things for pediatrics to think about. Insulinomas, and we'll kind of come back to that. What's this? Aki, yeah. Is this ripe or unripe? Yeah, if it's open and red, it's ripe. People, apparently, this was a patient at Kings County that told me, who came in vomiting after having some Aki and was like, I'm pretty sure this place might have been prying open their Aki fruit and lying about it. You worry about hypoglycin A. This is maybe a little bit more common in our population, but not that common. And you get Jamaican vomiting sickness, you can lead to liver failure, and you can get hypoglycemia. Okay, so let's move a little bit on to treatment. First, a good way to think about it is feeding is the most important way to do it. And we're going to use cookies to just kind of make it an equivalent of what we would normally give from a dextrose fluid standpoint. So using a standardized Chips Ahoy cookie, they're actually a little bit more than 50 calories a piece. So you're even exceeding this. But one 25 gram, so one D50 amp which is 50 cc's. And so 50% of that is 25 grams. That's 100 calories. That's 2 Chips Ahoy cookies. No milk. I mean, I don't know if I would drink Kings County milk that's been sitting on unrefrigerated all day, but you know, maybe it's ultra high temperature pasteurized and I don't know. So feeding somebody 2 cookies is better than giving somebody an amp of D50. So if they can tolerate PO, this is always better. And somebody can eat, you know, who only eats 2 cookies? The graham, I'd have to look at. You know, the honey made, we could look it up. Somebody can Google it right now. What's the calorie count in 1 graham cracker? And there's also, you know, it's purely, you know, simple carbohydrates. It's just dextrose in there. Whereas, you know, the bolus, which is why it's better to use calories than just saying how much sugar, is this will last a lot longer. So those 2 cookies will last longer. They won't spike the sugar as much. And so if you can feed somebody easily more than 2 Chips Ahoy cookies, maybe we should look at Famous Amos, like the little mini cookies. So a whole liter of D5, so 5%, right? That means 5 grams per 100 cc's, so 50 grams in 1,000 cc's, and that's 4 cookies. Very easy to exceed. The whole bottle, you know, again, only has 200 calories. Like you're really not giving people very much of anything with D5. Okay, D10, you know, it's getting a little better. 8 cookies. That's a lot of volume to just get 8 cookies in. It's not as bad as the D5. So I hope that drives home a little bit of the point of feeding people is much more efficient and better than fluid. So, but many people we can't give food to for a variety of reasons. If they have a PEG tube, you can feed them through the PEG tube, even if they seem to be altered or not able to tolerate PO. So D10 over D50. And this you might get pushback from both nursing and whoever you're working with. But let's just count a few ways of why I think D10 is actually a better option than D50 for even symptomatic hypoglycemia. So the first one is it's much easier to overshoot with D50. And our next point kind of follows this. When you do, and there are studies of giving D10 and repeat boluses, like I think in one study is like 100 cc boluses or 250 cc boluses, you're able to get people more to euglycemia instead of hyperglycemia very easily. And so what happens when you get to hyperglycemia? This is only true for people who have a functioning pancreas, but you get rebound hypoglycemia. So when you give somebody a big giant bolus, you make them hyperglycemic, their glucose goes up and we can go back to that pancreas, right? And what happens? Insulin gets secreted, and that insulin secretion causes them to become hypoglycemic again. So a lot of what we end up battling with patients who have symptomatic hypoglycemia, and then we're like, oh, they became hypoglycemic again. You have to immediately admit them. You have to start them on a drip, and it escalates the care that you're giving. That's not necessarily related to their problem, but it's more iatrogenic. It is hypertonic. You know, if you're giving somebody D50, this is a very hypertonic viscous solution. If you've ever just squeezed out some into a little cup and compared it with D10, it's considerably thicker. It's like syrupier. It's hard to push. If it extravasates, it can actually cause local tissue injury. And you really should be pushing it over 2 to 5 minutes. It's not how we usually push it, but if you don't have a good, 18 gauge or at least a 20 gauge, this is not an easy thing to get in quickly. You can hang up, a bag of D10 and get them, 250 cc's gets you that exact same amount. You can run it pretty quickly. You can, pressure it in, and it's much easier to give. These are 2 studies. And we have good data. I think one of them is from the shortage, but we've had shortages of D50 many times, and we should always have plans to handle shortages. And this can work both ways. If you have a shortage of D10, then you're going to be using D50. But we've had shortages of D50, I think, a lot more often than of D10. And there's good evidence to show that people get their GCS back to the exact same level and the exact same speed, whether you're giving them D50 or D10. And you have less, overshoot, less, rebound hypoglycemia, and it works just as well. So there's a good ALIM article if anybody wants to read that, kind of summarizing all of that in a little bit more detail than I just gave you. Okay, how to dose dextrose. Pediatricians are probably a little bit better at remembering dosing. At Kings County, I think we often underdose D50, which I guess helps us prevent the overshoot potentially and maybe prevent the rebound, but it is technically underdosing a little bit. You should be giving people around 0.5 to maybe even 1 gram per kg. In kids, there's a good teaching. Does anybody remember how to choose the dose and the concentration for pediatrics? Right. So for 5 cc's per kg for D10, 5 times 10. So D25 would be, what would be the dose? Right. And again, for kids, for neonates, we're giving them all D10 and it works for them as well. So again, there's good support to say, give D10. We're all kind of focused on, here's the thing I can push really quickly. But D50 probably is just as good. What about glucagon? What do people think about glucagon? Makes them vomit. So you might get asked for it for, esophageal foreign bodies. The evidence is not so clear on that. Sometimes we talk about it for beta blocker overdoses. Does not work for calcium channel blocker overdoses, and even for beta blocker overdoses, the evidence is very poor. But for hypoglycemia, only if no IV access. Is that ever really like a reasonable answer for almost anything we do? Not really. It is, whenever we all order, insulin protocols, a drip, daily insulin dosing on OBS, we're all ordering this, but really nobody should be rescuing somebody in a hospital setting with glucagon. It's fine for in the field, somebody, who they really can't get access, but once they're here, we should be able to get access. Even in IO, a lot of patients who are hypoglycemic, going back to the liver, glucagon, you need to have glycogenolysis occur, right? That's how it works. So you need to have glycogen stores. A lot of people who are hypoglycemic, especially kids who are the hardest ones to get IVs on, are the least likely to respond to glucagon. And I've seen that. So, you're better off just going to the IO if you really can't get access, if the person really looks terrible. Octreotide, somatostatin analog. This is really good for certain populations, but again, you need to have a functioning pancreas. How does that work? Well, it binds to the somatostatin receptor. It decreases CAMP. Decreasing CAMP inhibits the exocytosis of insulin. And so it shuts down the secretory functions of the pancreas. But you need to have a functioning pancreas. So people who are type 1 diabetic, who are hypoglycemic, this will have no effect. But it is reasonable for somebody who has like an insulin overdose, we'll talk about in a little bit, if they have a functioning pancreas. All right, so a little bit of a case. Have a 65-year-old male, history of diabetes, presenting as a stroke code, finger stick is 35. What do you think might be going on? Why are they hypoglycemic?
Either insulin, haven't eaten, they exercise.
It's a broad differential. Insulin, assuming it's not an intentional overdose, generally it's something wrong, like elimination, worsening CKD, AKI and CKD, or just AKI. Same thing actually with the sulfonylureas, most of them are renally excreted. And so usually somebody has not intentionally overdosed, but they've taken too much. or they effectively have taken too much because their elimination has decreased, or, they have decreased PO intake and they're taking like a standing dose. So let's say it's a sulfonylurea. How does sulfonylureas work? So they block that ATP sensitive potassium channel, which means that they then are kind of chronically keeping that calcium channel open. That, remember, has the influx of calcium, which causes the exocytosis of insulin. It also means that you're more sensitive to elevated levels of glucose. So people, when they get really high, are more likely to drop more quickly because they're going to have more insulin coming out. And as we talked about, you can shut that down with octreotide, which is why we talk about that as being the kind of treatment for sulfonylurea overdose. So first is feed the patient if they can. Again, Chips Ahoy cookies, whatever food is available. Sandwich, this can be challenging at Kings County. Better than fruit juice because that doesn't have anything but, just water and sugar. Those will get them up quickly, but you have the same kind of overshoot issue and they won't last for a long period of time. If you can't, again, I would say give D10, whether or not you're doing a bolus or a drip, I think, and you will, for all of this, ask 10 toxicologists the same question and you'll get 20 answers. From a practical standpoint, bolusing the person is probably better. There's a lot of issues with drips, but you can, sometimes you're balancing those two issues. So a drip has the problem that they run out, they stop working, nobody's paying attention to them. You have a sense of security that they have dextrose running, but again, it's a very small amount unless you're giving them large volumes. And then if somebody's like on a floor already, and we've had RCAs in the past of admitted patients who don't have adequate finger stick frequencies and die from hypoglycemia because their drip runs out. So I would personally bolus them and then feed them after you get them awake and try to avoid the drip. If you're within a reasonable time frame, you'll hear different things from different people, but 2 hours, if you think this was a intentional ingestion, give activated charcoal. And then there's always this question of whether or not to give the octreotide, and you're going to get different teaching. And some of this comes down to how long you need to monitor the patient. If there is some data, it's mostly older sulfonylureas that people can have rebound hypoglycemia, even like greater than 24 hours out after getting octreotide. Octreotide does not last that long, even sub-Q, it's probably 6 hours. More evidence shows that probably are fine watching somebody 12 hours after giving a dose of octreotide. If you talk to poison control here, not every poison control has the same opinions. They'll say, try them for 12 hours. If they fail after 12 hours, then give them octreotide. That's a really long time to both be in the emergency department, and it's a really short time to be potentially hospitalized just to watch to see if they have rebound hypoglycemia. I find giving it up front gets them out of the ED a little bit more quickly. It gets them safer because it's very rare, and unless this is like an intentional overdose. So for your like older patient who maybe has a little bit of an AKI, who has decreased kidney function, worsening CKD, a single dose of octreotide is almost always enough. But then you really need to watch them for at least 12 hours. And that gives you like 6 hours of the octreotide functioning, and then another 6 hours of just how they're eating. And it's important to watch them for at least 12 hours after getting octreotide. Again, poison control, and we do have a hypoglycemia pathway that uses that 12 hours after octreotide. Poison control will recommend 24 hours. And I think for any intentional overdose, you should err on that, and that patient's not going home anytime soon. So your concerns about dispo are very, very different for that intentional sulfonylurea overdose. But this patient can't go home right away, even though they're eating, they're drinking, they look great. And generally the way I do the finger stick frequencies is, they're on Q1 hour. Once they pass Q1 hours times 2, that's 2 hours, then switch into Q2 hours. Once they've passed Q2 hours times 2, that's 4 hours. Then they can be on Q4 hours. That means they can go to the floor. If they fail making it to Q4 hours, then you have to get an ICU consult, because they can't do, sorry. I don't know how I jumped that far. They can't do more frequently than Q4 hours. And again, that's what ends up getting us at Kings County into trouble, is they don't even always get done Q4 hours when they're supposed to be. And you have to be on top of it in the ED. You do have to think a little bit about night and day, because patients are sleeping overnight. They are not eating. It's hard to, convince the person to eat. And that also will push me to give octreotide a little bit sooner. If it's the middle of the night and that patient is hypoglycemic and I can't be on top of them eating, I'd rather give them a dose of octreotide and get them through the night until the morning when they are eating again and looking better. And that's why, it's even more important for kids where you're thinking about day versus night. But even for adults not eating, they're sleeping, it's hard to get those finger sticks. You might consider doing the drip just overnight and see if you can get them out without octreotide. But again, I would say 12 hours, not on a drip, just get a dose of octreotide. If in the morning they're fine, then you can probably discharge them or have admitted them and it's totally would meet, or place them on observation. Okay, so here's our next patient. I have a 27-year-old male. They've been taking care of their grandmother who has insulin-dependent diabetes, and they're pretty depressed taking care of their grandmother, and now they're found by grandma unresponsive, and they have a finger stick of 23. So what happened? Hypoglycemia from taking grandma's insulin. Again, dextrose is the treatment. In this case, you're going to have to probably put them on a drip. One thing you can try and do is you can try and find where they injected it. The concentration of insulin is usually about 10 units per 0.1 cc. And so you can get like 100 cc's pretty easily in just 1 cc, 100 units in 1 cc, or even like 1,000 units in, a 10 cc vial. And so that's not a tiny amount of volume, but it's not a huge amount. And so if you can find where they injected it, sometimes you can actually pull off, excise it and decrease their length of stay. As I talked about before, this is a patient you can consider giving octreotide to because they themselves don't have insulin-dependent diabetes. They have a functioning pancreas. That's really helping you with whenever you give them a bolus or start them on a drip, that if you overshoot, that they're not going to secrete more insulin and then become hypoglycemic, that you're kind of fighting against. You want to try and feed this patient. If it's overnight, you're going to have them on a drip most likely, and that you just can't get around. But if, again, they graduate with those finger sticks, as I talked about before, then maybe you can put them to the floor versus needing an ICU consult. All right. This is actually, this is my son, but this is a case that I got consulted on as a fellow. You have a 3-year-old male, no past medical history. It's 7 in the morning and patient gets brought in by EMS for altered mental status and hypoglycemia to the 50s. Parents just couldn't wake them up. What are you guys thinking? So ingestion, so sulfonylurea is reasonable. They're probably not injecting themselves with insulin and drinking insulin. We wish it worked, but it doesn't. What's something that's really important to send? It's kind of up there. Yeah, so ethanol, C-peptide, and insulin levels, because you do worry about, Munchausen by proxy. You worry that the parents are maybe giving them insulin, and so you want exogenous insulin. So you want that C-peptide, you want an insulin level, because insulinomas are they're not common, but they're much more common in this age than in adults. You want to get ketones, because one of the common causes or diagnoses for hypoglycemic patients, especially in the morning, is IKH, which is idiopathic ketotic hypoglycemia. It's mostly seen in kind of like skinny, not the best fed kids, maybe for whatever reason. Toddlers can be really picky eaters. And then again, as I mentioned, they have lower glycogen stores. And so a long overnight can often lead them to become hypoglycemic. They don't have enough glycogen to respond to that hypoglycemia, and they become ketotic. And in the morning, they're just totally altered. Ethanol is also, as Dr. Silverberg, I think, mentioned before, is a common cause, especially in kids. If you had a party the night before and the kid went around and drinking stuff that they didn't know about, can all be caused. There's also a million inborn errors of metabolism that you have to think about, and that upstairs can figure out. But these kids, dextrose is needed. Again, don't do the glucagon, feed whenever possible. All right. So toddler number 2, you have a 3-year-old male found by grandma playing with her medications, which include glipizide, which we would think of as being like a potential 1-pill killer. Patient's otherwise totally well. What do you want to do? Get a finger stick. It's normal. You could give them activated charcoal if it's within that same kind of 2-hour time period. Now, if you're not feeding them, if it's the morning, you might be able to do it during the day. You could say, I'm not going to feed you, and I'm going to watch you for 6 hours. I'm going to starve this 3-year-old toddler, which could be its own battle. And there's good evidence to show that not feeding them 6 hours would be enough to clear somebody with an unintentional exposure. If you feed them, though, that might hide them being hypoglycemic. And then you would worry that, especially like overnight when they're not eating, that they're going to drop. And there are, poison control studies that show that patients who you feed could have rebound hypoglycemia, or not even rebound, but hypoglycemia that you totally missed greater than 24 hours out. If it's overnight, maybe you can just watch them in the ED for 6 hours, not feeding them. Much easier. You don't need to fight with the kid. They're not expecting to eat. So time of day, again, is very important. But if you decide to feed them, you're admitting this patient for observation to make sure, for at least 24 hours, to make sure that they don't drop. And somewhere within there, you might think about if you could do a pill count, which is not always so easy with grandmas, medications, that you might think about, I did my pill count. I'm pretty sure they didn't get into anything that might make you feel a little bit more comfortable one way or the other, but you definitely want to talk to poison control. So hypoglycemia is a broad differential. Feeding is the best treatment for most people when they can. I would say treat with D10 over D50. Again, for most patients, even symptomatic, insulin overdoses, you're going to end up needing to give a drip. Octreotide is grateful for sulfonylurea overdoses. Observe for at least 12 hours after that first dose, if not up to 24. And if you're observing in the ED asymptomatic exposures, then without food, you can do that for about 6 hours. If you're feeding them, then you're doing that for 24 hours.